Right. So as was mentioned, I go by Q or Qasim. I'd like to say just say awesome, put a K before that. But that's got an old, so I just go with Q. Not because of James Bond or anything. Um, it just somebody started saying it and stuck, and just stuck with it. So I'm talking about don't be a hypocrite. I've got stickers that say that, but too bad we are doing this remote. Otherwise, I would have brought them. Maybe one day I'll see you all and hand you some stickers. The idea here is to talk about some of the issues in healthcare security that blue and red team will benefit from knowing it, from figuring out ways to combat those issues. I'm not trying to bash healthcare IT. I'm not trying to just talk about all the wins. Instead, what the talk I'm trying to give is to inform the blue and red team. How can you pawn a healthcare organization? On the other hand, if you're a blue teamer, what to look for. All right. So let's move on to who am I? Well, like I mentioned, go with Q. Used to work at Colfar Labs, not as of yesterday, free agent now. I'm not going to do wink, wink. Hard to see that with these glasses. But I've been largely focused on healthcare clients, be it small to large healthcare organizations, be it health plan providers. I started my professional career as a systems engineer at Cerner, which is a pretty big healthcare software company. Did some HIPAA and HITRUST assessments where I learned more about Microsoft Excel than I learned about HIPAA and HITRUST. I learned that Excel is really the tool of choice in that. And that's my Twitter handle. I talk a lot about politics. I complain a lot. So you might not learn a lot about security just by following me. But if you want to just hear somebody complain, it's right there. All right. So before I talk about the issues, I want to introduce what that healthcare IT environment looks like. All right. So in most commonly what you see in healthcare environments, you are going to have the EHR database, the electronic health record database, which is the source of truth for all healthcare data. That's where everything is going, and that's where everything is coming from. You have the billing, reporting, scheduling, charting servers that are doing all the metrics, that are showing all the data to clinicians, to folks who are sending you that $50,000 bill for just one pill. They're all using that, and it's pulling that from that EHR database. It's not always just one database. Because HIPAA requires you to have the archived data for a while, and then there are some other contractual requirements. It's just good practice to not forget who your patients were 5 years ago. A lot of organizations are going to have old EHR databases. As they move to different electronic health records, go from Cerner to Epic, from Epic to McKesson, from McKesson to eClinicalWorks or whatnot, you will see those old applications and the databases related to them still in the environment. A lot of times it's Oracle or MS SQL. MySQL has started to become quite common. I know Cerner Ijaz that I used to support uses MySQL for that. Then you'll see some connectivity engines. So these could be Microsoft Windows servers. These could be small Ubuntu devices. What they're doing is they are facilitating the conversation between the medical devices, be it your smart beds, your ventilators, the bedside devices, their conversation with the reporting apps and with the EHR database. A lot of that conversation is HL7 encoded. We'll talk about that later, but what it means is using HL7 encoding to make sure that other apps, other databases can understand what's being sent and received. Oftentimes it may be encrypted over HTTPS, but more often than not will be unencrypted. Okay. Then you've got the outsiders, right? Your third parties that you're working with. Could be the university medical center working with a university, or the research center. It could be through a third party like an EMR vendor. Cerner, for example, when I used to work at the data center, we hosted the data for about 20% of the hospitals in the US. So a lot of that was done through the tunnels and VPN connections and whatnot. You have remote users nowadays with COVID. A lot of doctors and clinicians have gone to work remotely. Then you have patients logging into their patient portals, but are sitting outside that EHR database, all right? Sitting outside that internal network to provide the output from the EHR database in there. Internal users and admins working with that environment, working with those devices, with the databases and whatnot. You may also have what I like to call lack of segregation. Well, everybody calls it that. So there's lack of segregation in there between the internal admins, the patient portal, and other devices. And that's pretty common. A lot of organizations are still trying to figure out where their medical devices are, because a lot of those medical devices are connected to your network, be it through wireless, oftentimes with WEP, be it through wired networking, or Bluetooth oftentimes. So a lot of them are still trying to figure out where those devices are so they can segregate them. And we'll talk about later how that comes into play when you're doing pen testing. So this is kind of the overall view in there. A lot of unencrypted communication in that network. Outside communication is very much encrypted nowadays. It may not be the cipher you like. It may not be the TLS version you like. It may not be the IKE version you like, but it's getting there, and it's getting much better on the outside. So I mentioned EHR. So you hear two terms, EHR and EMR, electronic medical record versus electronic health record. The health record is going to be everybody, all the hospitals you've been to, all the care providers you've gone to, all different tests you've gotten, right? So it's going to be a merger of all that. Versus EMR will likely be just one provider's office or one doctor. Think of EMR as like a paper chart, versus EHR includes more enriched data that can help. For example, even billing data and scheduling, which doctor you saw, which device were you connected to, which room you were in. This is Cerner power chart. Cerner, Epic, McKesson, and Nextgen are the big players that you'll hear a lot about. A lot of new ones are coming out too. A lot of the medical devices will likely have their own EHR. For example, GE Muse has its own page where you can go and search for previous patients. A lot of times they're pulling this data, especially when it comes to radiology, where you're working with very large-sized images. Those oftentimes get stored on NFS shares or on Windows SMB shares. So that always comes up being an interesting thing to look at, see what the level of authentication and access control is like for that. Because we found NFS shares that were just no encryption at all. One of my colleagues recently found one where there were 13 billion patient records being dumped into this one NFS share without authentication. And that was because they had multiple EMRs, Cerner, Epic, and a few others, and they were all just merging into one big database for archive. They just didn't realize that the NFS share was unencrypted. All right, other things you'll hear, we talked about connectivity engine, which really is your connection between the EHR and the medical device. It's kind of like a temporary storage. It's taking the HL7 encoded data, making sure the database understands it. So all the devices are not directly sending things to the database, because that could be problematic, especially when you're trying to provide cross-platform or cross-vendor compatibility. The medical devices have two functions. You have the order and you have the result. Order and result was a lot I heard while doing my night shift at Cerner. Order really means is the device is being told to do something, right? So, hey, device, what's the patient heart rate right now? It would sometimes have a patient ID. What a lot of organizations are going with nowadays is association ID. So instead of in the database you seeing an ID specific to that patient, you will see an ID specific to the association of that patient with that device during that time. So if I visited a local hospital, every time I visit and they put me on a device, for whatever reason, it will create that association, that encounter, and it will have its own record. You then have to cross-reference that with another database to find out my name, my ID, like medical record number, and other information. So if you were able to get the database, your hands on the database that stored that medical record result in order, all you would generally, in an ideal world, see is what the heart rate was, which device it was, possibly which room it was, but not my name or not my specific identifier. A lot of lab robots are really just assembly lines. I've got a client, well, I used to have a client, running an MS-DOS robot. This device takes orders, sends them to the medical devices, sends the results back. It kind of functions like the middle person assembly line, and it's running MS-DOS, and this is very recent. They just cannot replace it. The organization is very small. It's a nonprofit healthcare organization, and to replace that specific device would be $5 to $10 million that they don't have. So they've put in contingencies, they've put in complementing controls around it, like isolated it so to avoid and mitigate any risks. And we already talked about EMRs and EHRs in there, so I'm going to skip that. So a lot of jargon in there. Let's talk about where the goods are. All right, and if you don't know which where the picture is from, if you guessed the Freddie Mercury movie, that's also good. But it's, yeah, you should know what that is. Anyway, talking about HL7 earlier, I like to call it man-the-middler's heaven. That's because the data is being sent in plain text. You have encoding occurring that really is working to provide cross organization and cross-device, cross-vendor compatibility. It's not working to help with the confidentiality of the data, or it's somewhat helping with integrity, but that's more with like error checking than really providing integrity at security level. HL7 is still being used. There's a few versions of it, but still being used quite a bit. There is a new standard out that we'll talk about later, but that's not being used much at this point. Every device you'll see likely is using HL7. Okay. And you can run a Wireshark capture if you are positioned in a man-in-the-middle location, and you can see that traffic going back and forth. Healthcare defaults, we're seeing a lot, especially that Muse admin account is my favorite, all right? You see me using Muse admin in here to gain access. This has been out since, I believe, 2015. Yeah, that's the CVE, and it was released at ShakaCon from Scott, and he did really good work on identifying defaults for GE devices. And at this point, we've collected defaults for a lot of different devices. Having worked at Cerner and other medical record companies, I collected some on my time that working with them on. But Muse admin and Muse background are the two accounts. If you are in healthcare IT, take a look at them. Let me tell you a story. Working with a middle-sized healthcare organization, a few hundred beds, got the domain admin in 10 minutes. The path was started by typing in Muse admin credentials in their Citrix endpoint. It had Citrix access. Apparently, the radiology device needs to work from home at some point. Got in from there, identified a Windows server that had the name Muse, something to do with Muse. Muse admin, as the name refers, is local admin on that box. That box was set up by IT, which at least the person who set it up had domain admin access. So within 10 minutes, went from being external to gaining the domain admin privilege. Muse background, I'm seeing a lot of it, but not as much as Muse admin, but these are definitely the credentials to know. There's a lot more credentials. There are credentials specific to Kronos, specific to Cerner, Epic. Just knowing them is very helpful because oftentimes organizations aren't changing them. Now, don't just go and tell the organization that they are screwed and they have to change this right away. The reason I say that is oftentimes it's very difficult to change these credentials. This credentials was put in 10 years ago, 15 years ago, and it's right now hard-coded in apps and in devices, and changing it could have patient health impacts, could kill somebody if the device stops working and something bad happens. So as you're working with organizations to help them understand the risk associated with this default, do tell them this is very bad, but just being realistic, it's not going to be an overnight fix, especially when any medical device is associated. So yeah, very commonly you've got Muse admin with VPN or Citrix access, and it works almost every time, right? Oftentimes when my testers are working on a healthcare organization, the first question I will ask, trying to avoid micromanaging, but the first question I will ask is, have you tried Muse admin? I think I need a poster on everybody's cubicle that says that. Unauthenticated VNC is still happening. A lot of it has to do with remote management of devices or devices that have computers associated with them. Starting to see a lot of password use in that. It's not as prevalent as it used to be, but it's still there. So do not ignore some of these basic vulnerabilities like unauthenticated VNC and bad passwords, because you will find them a lot. In this case, Pyxis, and this is not necessarily on the vendor, it's how it was set up by the organization. We could, at this point, dispense medication for us. We could also pretend somebody else, since we had credentials also in addition to this, pretend somebody else dispensed medication that they shouldn't have. Lack of authentication. I talked about those 13 billion patient records that we got from an NFS share. Also seeing on the left here, GE Muse web server. This organization was no longer using that vendor, but they kept the application running due to HIPAA regulations and wanting to go back and look at old data from the patient. So as you can see on that border over there, I don't think we've been doing that since the 90s. Back in the day, we thought that was cool. We don't think that anymore. You have a lot of patient record storage in plain text files and the network shares. For example, somebody will take notes because the EMR was down, or just taking notes on the side and left them in their documents directory thinking nobody else will see it. Well, problem with that is the IT has no business knowing that, reading that patient record, reading that, the note about that patient, but IT likely has access to your documents folder. So creating that separation is important, and teaching the users to use the EMR for note taking or use some encrypted apps. If you are going to use, take some offline notes, put them in Microsoft Word or Excel and encrypt it, because it does have the password capability. This is very common in internal networks. You don't often see that on external. What I did see in external a few times was things like a help desk. And this is one of my past colleagues, I think it was Akshay, he found was the organization's help desk tool was publicly available. If you wanted to submit a ticket, you had to sign in, but you could review previous tickets. So one of the things we did was just search for the word password or the name of the CEO, and we found old password resets, recent password resets, password policy, quite a bit of IT notes that helped us gain access to some passwords we shouldn't have access to. All right, so it's important to think about the authentication, and don't just stop at authentication. Think about authorization too. Just because you are authenticated, you have the business being in this building. Do you have the business being in this tool, in this application, in this share? Oftentimes we are seeing applications interacting with a network share where the user has to sign in to log into the application, but the database the application is using does not really require that. Or the database credentials are saved unencrypted in C program files folder. So the user could just log on directly to the database. And at that point, the authentication kind of goes out the window too. Then, of course, nobody needs a password manager. At least I think so. Seeing a lot of passwords stored in Excel files and Word documents and Notepad. my favorite ones are when it actually says password, and like this one right here kind of specifies which website or app it is for, what the username and password is. I've even seen times where it said critical application passwords or critical application credentials, and that was definitely a fun one to take a look at. Where it gets really tricky as a consultant is when your point of contact, the person who paid for the pen test or person who you were interacting with in the pen test, is the one storing credentials in plain text. That's when you have to make the consulting choice of, do I tell them or do I tell that specific person? I'm not gonna go into ethics of that. People much smarter than myself can probably tell you more about it, but find a balance. And I've done a lot of physical assessment of hospitals, especially when I was a HIPAA assessor. Would go on site to try to find how the organization is doing from HIPAA specific rules. For example, are they posting patient privacy notice in public areas? Are they doing anything that will just violate the fire marshal rules? Are they saving data in bad locations? And we found a lot of instances, especially with small clinics, where you could just walk in and have access to patient data. Just pretend like you're with a patient and walk into a patient room or walk into an area like that. We even, and I couldn't find that picture in here, but we even once found, it was a small clinic. They had their server rack sitting on top of a fridge in a kitchen. And it had the EMR, it had the network switches and all that, and it was not too far away from the sink. We also oftentimes saw things like having the doctor manage IT or having the doctor manage security. At one time, we were interviewing this clinician who was managing IT in that clinic. So when it came to configuration management, it came to asset management, he was the person to talk to. And he was a gamer, not a security person, not an IT person, trying to do the best he could. The way he was doing things was he would go to Best Buy and grab the best laptop or desktop he could find within the budget, come and set it up. And that's it. That is the configuration management. That is the asset management we're doing. I'm just writing down the serial number on a piece of paper and sending it to IT and corporate. This person, for whatever reason, was also responsible for managing the local small EMR app they had. And that EMR app, I remember he was a gamer, he had forwarded the ports from outside to the EMR. Makes sense, right? You're running a web server, but he did not think about encryption or passwords. The EMR was publicly available at that point. So anybody could log in, or they could just scan the IP space and find that EMR right there without authentication. They did not have a lot of patience. It was a rural area. So the disclosure wasn't in millions or anything like that, but it was still a pretty big deal. And that brought us back to thinking, how many other places in this organization is that happening? Do not ignore the visitor area, all right? That right there is the networking device sitting in visitor area. As you can see, the legs over here for the chair, for the visitor chairs. So we just plugged into it. We had network access right away. They didn't need to do any social engineering. They didn't need to do any lock picking or anything like that. Just sat there, plugged in, and now we have internal access. Now let's go and find other vulnerabilities that might affect them. One place to keep an eye on to look at is the OCR Breach Portal. Office of Civil Rights is responsible for enforcement of HIPAA. If you mess something up, they're the ones you got to report to. And they report to the Health and Human Services Office, HHS. And the OCR is who you report to when you have a breach. And then they put that on their website. There are some other rules around breaches we'll talk about later. But this website, ocrportal.hhs.gov, is where you can go and look what breach your local provider may have had. So this is Colorado providers. What type of breach it was, what location. So for example, in this case, it was a network server, hacking, IT theft. This right here is a straight up theft an electronic device. So somebody maybe walked away with a mobile phone that had PHI on it, or walked away with a drive, or a laptop was stolen. You've got a lot of paper and file exposure too, because the paper is still used. Even though you have the electronic medical record, paper is still being used quite a bit. One reason could be the EMR is down for whatever reason. Another reason could be the patient wants paper records. They're still also using CDs. They haven't upgraded to MP3 players yet, but CDs are still being used because they're low cost. They just work. All right. So a lot of that could also be stolen. You have a lot of a lot of organizations are using vendors like Iron Mountain and others to store tapes and whatnot, but they also use shredding companies to come and take away the sensitive paper to shred and get a certificate from them to prove that things were shredded. But one of the things we found while we were doing a lot of those HIPAA walkthroughs was you would find filled up shredding bins, or the secure disposal bins sitting on the dock with nobody around to take a look at it. So you could just walk away with that bin. It's pretty easy to break the lock. In fact, the bin is plastic. You don't even need to break the lock. Or you can just reach in and grab the paper and walk away with that. You may have something fun in that, right? So that's what you see sometimes in paper and films type of theft in there. All right, so I talked about a lot of bad things, a lot of things that are the reason I try to avoid going to doctors. Although I'm kind of concerned with shamans looking for electronic payments now, so it's not like I can go to them too. But let's talk about some of the good things that could help, that are trying, that we could improve upon and make things somewhat better. Just gonna pause here for a second. When I was interviewing folks, when I was a hiring manager for HIPAA and HITRUST, one thing I looked at was, if somebody's talking about HIPAA experience, how are they spelling it? Is it HIPAA or HIPAA? All right. And the reason for that is Health Insurance Portability and Accountability Act. So it's HIPAA. The idea around HIPAA was to make the data portable and offer privacy. That was one of the main reasons for the EMR, the electronic medical record revolution in early 2000s, that really went on pretty strong till 2015, really offering you the ability to move away to a different doctor and still have your information with you, but also providing privacy. So your information is not being used, for example, for marketing without your approval and without it being de-identified, or your information is not being sold. And HIPAA security rule that came on later on talked about how to implement some safeguards around that patient information, right? So you've got the administrative safeguard. For example, there should be access management. We should evaluate our safeguards or security policies often. This is where around like policies and procedures around identity and access management. Then you have physical safeguards, such as do not let anybody just walk through the patient area without showing some identification, without actually having a reason to be there. Put a lock on your front door. Putting some physical access controls where you can also monitor them, right? And then there are some technical safeguards like encryption and authentication. Now, a lot of that is where I have my gripes with HIPAA. And that is, a lot of times when HIPAA talks about good things like encryption and pen testing, it says if reasonable and appropriate. In my experience, and I'm in no way an authority on HIPAA, but in my experience, the Office of Civil Rights is not doing proactive enforcement. They're not making you do encryption. They're not making you do pen testing until after you have had a breach. When you had a breach, they will come in and they'll ask you why you didn't do encryption. They will ask you why you did not evaluate your technical safeguards. But generally, until then, there are pretty easy ways to be HIPAA compliant. HIPAA also, in very detail, talks about risk management and risk analysis. And this is where it takes a lot from NIST. A lot of provisions in HIPAA and a lot of ways organizations do HIPAA analysis or HIPAA-based risk assessments is based on NIST. So when we talk about encryption, however weak the HIPAA rules on that may be, it is still based on NIST. So you still have to think about DES is not going to work. I have to use AES, right? So yeah, because of HIPAA, the first rule of nursing home, do not talk about nursing home. So HIPAA minimum necessary principle is another thing to think about when you're looking at pen testing or just any security analysis or just trying to secure the information in hospitals, is to identify ways that enforce this minimum necessary principle of any use, disclosure, or request of the protected health information, your health record, should only be done when it's minimum necessary to accomplish the purpose of it. What that means, to break it down and to give you a good example of it, is if you are in the ICU, right, intensive care unit, and you have nothing to do, there's no reason for a labor and delivery doctor to have an interaction with you, they're not assigned to you, they should not be looking at your information. If you are a doctor yourself, you should not be looking at your own sons or your own daughters or your own parents' information without actually, working with them, without being assigned to them. So it boils down to handling the health information on need-to-know basis. Many organizations are going to use tools like Fair Warning or Splunk to alert on who accessed what data and did they have a reason to access it. A lot of hospitals, when dealing with celebrities, will put a VIP flag on the health record of that celebrity and monitor all access to it to make sure that you do not have some nurse or some doctor in a different department or different location taking a look at that celebrity's patient health record and leaking it to media. All right. A lot of common things they look for, the rules they look for is, was it the same address as the staff that they looked at? Was it the same last name as the staff? VIP status in different departments. Did the person from labor and delivery look at ICU patients' data? Did somebody from the nursing home take a look at somebody from ICU's data? And if they did, that's likely not what they should be doing. Sorry, I had to make knock knock joke in there. It's not my meme though, it's somebody else's meme. So if you don't like it, don't blame me. All right, so we talked about breaches earlier. I kind of showed you some statistics on that. So HIPAA high-tech breach rule, what it talks about is the notification of it is, first of all, you have to define, right, what the breach is. And according to HIPAA, according to the OCR, the definition of breach is the unauthorized acquisition, access, or use or disclosure of PHI, which compromises the security and privacy of that PHI. All right, so it has to be unauthorized. It has to compromise the security and privacy of it. There has been some debate on if ransomware itself is a breach, especially when there is no evidence that the data was looked at by somebody else. There's no evidence of data being exfiltrated. But lately the guidance has been that it is a breach unless proven otherwise. If more than 500 records were breached, and before I talk about that, let's talk about what a record is. It could be in each row in the database. It could be every health record of you, every visit you made to the hospital. And if there's a copy of it, let's say I went to a hospital, of course, the hospital should keep backups. There should be backups of those backups. If the backups were also disclosed, then that also counts as a separate record. So if we have 500 records, but you also have the backup tape of those records, and those are also disclosed, that is 1,000 records in total, even though they're not unique. So when I talked about those 13 billion records earlier, those were not unique 13 billion records, but they all count when it comes to the fines, when it comes to enforcement. So if the more than 500 records are breached, then you have to report within 60 days to the patient, to the federal government, which would be the Office of Civil Rights. And also, if you had a large breach, you have to go to the media. If it's less than 500, then you just notify the OCR on annual basis, but you still have to let the patient know though. So part of the reason for that is you don't want to be writing reports to OCR for every record breach you may have. You might have just one record breached. Let's say it's once a day. That's still going to be a lot of forms to fill. So you're going to combine them into one big notification at the end. This is the best use of HIPAA for me that I like, right? It allows you to avoid those conversations with pesky family members. All right, something is, if the data was disclosed, but it was encrypted, well, still kind of a breach, but you are not able, there's no disclosure to be technical about it. All right, the unencrypted PHI, the PHI that has not been encrypted, could technically be HIPAA compliant. But if it's not encrypted and you got a breach, then you're gonna have a huge problem. And to be fair though, if you read more into the rule, they're not necessarily saying that you just say, well, I don't need encryption and that's it. They're still looking for reason why you don't need encryption, right? We try to address the issue. What controls you have in place that make it reasonable for you to not have encryption. The PHI was shredded in a way that makes it unreadable, not necessarily a breach, right? Or you may have issues like, for example, a nurse or somebody in a physician's office, let's say a nurse or a doctor, accidentally gives a medical summary to wrong patient, who immediately sees it, that's not hers, and returns it back. That is considered, and then the rule, disclosure to a person unlikely to retain that information. So if that's the case, if you can prove that's the case, then it may not be a breach. Then again, not a HIPAA authority on this. You still should work with your compliance department. They are really the ones who understand these things very well. And again, in the end, whatever the government says goes. So if there was a breach, what's going to happen? Well, the Office of Civil Rights will be in your business. All right, they'll come in, they'll require you to conduct a risk assessment. They will require you to have a corrective action plan for whatever issues were identified. They may even sometimes do surprise on-site visits to make sure you have good physical security and take a look at your papers. In addition to HIPAA, nowadays there is HITRUST. I have yet to find somebody who loves HITRUST, but to be candid, there's some really good technical rules in HITRUST that I like, being technical. HITRUST is kind of a mixture of your ISO 27002, your HIPAA, NIST, FedRAMP, PCI, a lot of things like segmentation it takes from PCI. It's got 3 different levels of requirements. Not every hospital is created equal, so they're not always going to have to be the same requirements for everybody. Every requirement needs to be rated for, is there a policy for this? Is there a procedure in place that talks about it? How well are we implementing it? And then, are we measuring the success of this requirement being implemented? And if there are issues, how are we remediating them? So HITRUST goes in a lot of depth to that. And this is kind of the reason why a lot of us consultants do not like HITRUST, because it does cause a lot of work. We talked about HL7 earlier. So let's talk about FHIR, right? FHIR is the next evolution. It still is, to some extent, you're trying to encode the information to make it cross-vendor compatible, but it supports RESTful APIs, it supports OAuth and JSON tokens, right? So it also supports the digital signatures. So it brings in the confidentiality, integrity, and availability of the data that we like to get to. It is not being enforced quite a bit yet. It's not being used by new devices. And to be candid, if the device is still working, the hospital has very little reason to change it. Oftentimes those devices can cost millions, or it can be, even if it doesn't cost a lot of money to buy the device, it could cost a lot of money to train people to use it, to train organization to implement that device. So where are the crown jewels? We talked about how I've been getting in. We talked about some of the issues we've seen. Once you are as a pen tester, you are looking at an organization, you've got domain admin or you've got access, things you need to look for are especially EPHI, electronic protected health record, the things in the EMR database, patient information and notepad files and whatnot. Count it. If you can get to a number above 500, you will really be scaring some people, and that's a good thing. All right, you need to be able to talk numbers with the executive leadership. Do not try the webcam shots. Speaking that from experience, one of my former colleagues, the guy who actually taught me pen testing, currently lives in Boulder. Him and I, we used to do a lot of webcam screenshots, and there have been times when I just wish I had not done a webcam screenshot. But there are sometimes organizations that want that so they can show risk. All right. Look for, if you're doing physical, look for printers, fax machines, copiers, right? The unsecured, unlocked bins I talked about, where you can just snatch the paper out, and that would be you grabbing access to PHI. So when I'm doing the internal network tests, I'm looking at oftentimes, starting with a responder. I know a lot of us feel too elite to use the responder, but broadcast protocols are there. May as well use them, right? Don't try to complicate the pen test if you don't have to. So a lot of medical devices and services are going to use broadcast protocols to do their work, especially when you have dental EMRs and other applications that are using SMB shares to do their work. They're storing data on SMB share and pulling it. I'm a big fan of CME, Crack Map Exec. Thanks, Marcello. Use the 80 defaults. The link I provided in the slides back there from ShekaCon has a lot of medical device defaults in there. Many of them are AD accounts, especially Muse admin. All right. Tattoo this, write it down somewhere, whatever way you like to do your password list. This right here is a really good credential to use. Use Metasploit or whichever tool you like to look for unauthenticated VNC instances, look for MS SQL. One thing, be very careful. Do not lock out the EMR database. I've been through that. I've seen that happen. The client still brought us back, but it was not a fun thing to go through. When I was working at Cerner, I went through some of these issues where the EMR database is no longer working or EMR is just down. There's an outage. And that creates a lot of friction between IT and clinicians that is not healthy for the security of the organization. It also means the clinicians now have to go to paper. They have to write everything down. And then they have to, once the EMR is back, put that information back in the database or in the EMR, which doubles the work. Also, now you have paper records that you have to worry about securing. So don't lock other databases. If try avoiding MS SQL if you can until you have good credentials. Maybe just try one password with a list of multiple usernames. So look for EPHI, look for creds, especially take a look at the SMB and NFS shares. You'll find a lot of stuff in there. Eyewitness and Peeping Tom have been really helpful for me to identify unauthenticated web apps that I could log into. Well, authenticated no login, that I could get to and get patient data. And again, count the patient data you receive, right? So if you are in MS SQL, do a select count all. If you are locking in, doing a physical, still count how many paper records you got, because the number of records you were able to breach is what will really help the security team get the funding. Privilege escalation. Look for clinical application binaries that have bad permissions on them. So you could do something with, with the power up, you could exploit them. Look for configuration files, .ini, .config files that are sitting in C program files or other specific application folders, or even on network shares. Oftentimes the way the application is installed on the share and then accessed is just because you have access to the share to read the PHI, the data. And the config file is also stored on the same share. You may also be able to read passwords for the database from the share. At that point, the access control goes out the window. Look for the environment variables. A lot of organizations, a lot of software vendors, due to the security concerns of configuration files just being out there, are moving to environment variables, which still, depending on your access, you could read. For external, I like to still use MuseAdmin on Citrix and OWA on the VPN, right? Grab some weak passwords with using Harvester, go after some portals. This is a Google Dork I've found to be very useful to find patient portals where patients will log in to find their patient records. Just be careful. Sometimes they are third-party hosted, so you'd want to take a look at the scope. Some common passwords you want to try, some variation of welcome. Very recently, we found an organization where we had over 6,000 welcome 1 passwords, or welcome 1 to 3. It kind of just went from 1, 2, and 3 every 90 days as they were changing the password. Org name or the mnemonic is often very common in the passwords, not just specific to healthcare, but everywhere else. The change of the EMR is generally an overnight event. It's a very extensive event, which leaves an impact on people's minds, and they remember it. And the event is called Go Live. You're going live with Cerner or Epic or whatnot. So that ends up in a lot of passwords. And of course, you've got the coronavirus or COVID happening, and that impacts what passwords are being used. All right. Complex medical terms, they're easy for the doctor to remember. I think they're not easy for you to try, but if you put them in a password list, then really it's not hard to try them. Always try the digit and first uppercase letter, because special character is not being used a lot still. As you are performing the pen test, it's important to try and avoid hitting the EMR or EHR right away. At least don't scan it. Don't put NASA scans at it. And if you're going to do that, work with the organizations to understand how they do it. So you're not going to just take it down on day one. Try avoiding scanning medical devices or battery backups. And as I mentioned earlier, a lot of organizations don't know where their medical devices are. Many might not even know what IP scheme their battery backups have. So helping figuring that out during scoping exercises is a pretty good idea. Look out for the MS SQL Server accounts, AD service account, medical device accounts. Talk to the client and understand what they're concerned with. Do not lock them out, because locking them out would mean you don't come back. Also, when you cause an outage, and I say you, and I've done that. I've done in the past, where once this one very common EMR, I typed in a percentage sign in the username field. It thought I was trying to log in as every user. All of us were trying to do was find SQL injection or something like that, but it locked out every user because it thought I was trying to log in as them. So try avoiding that, because that will create a lot of friction. The security is already seen as a blocker, right? As something that prevents you from patient care. That's a very common excuse I've heard, is that 2 seconds that it's taking me to type in my 2FA is taking time away from the patients. So try to be as easy, as collaborative as you can, right? Collaboration is the key word in there. And as I mentioned earlier, try avoiding webcam shots if you can. As we are scoping, again, find places where you should not be doing a Nessus scan or Koala scan or Nexpo scan, because you don't want to take things down. Look for sensitive devices and networks that you should not scan, and also look for how the organization's network is laid out, because that map I showed you earlier, it's all flat. A lot of healthcare organizations are still flat organizations, flat networks. So it's very much possible, if you're pen testing University Health Center and you're hired by the health center to pen test them, your Nessus scans could very likely, or your Nmap scans could very likely be hitting the university, which is not in scope. So figure that out in the scoping exercises. All right. Identify any password lockout policies if you can. If the client doesn't feel comfortable telling you, because it's not a pen test, it's a red team, well, go and look for that in Google. Use Google Docs. You can find a password policy very commonly. So you do not lock out clinician accounts, because they may be in the middle of some very sensitive care. They may be working with an anesthesia machine at that point, right? So be very careful with that. Work with the organization to figure out the vulnerability scanning schedule, especially if it's a pen test and you have to do vulnerability scanning. try to figure out if they want you to do heavy lifting, heavy activity after hours. Now, one question I often follow that up with is, if I am working after hours to do this scan that has some little possibility of causing issues, do you have anybody working at night? Because there really isn't a point making the tester, the scanner, do the scan at night, when if something goes down, there's nobody available to call. If you're doing physical, try to avoid, nuclear medicine or areas like that, unless you want superpowers. So work with the client to understand which areas you should stay away from. If you're a male, you'll likely be asked to stay away from labor and delivery area. And they may have some, very specific research areas that they want you to stay away from. If you're in medical, if you're in wireless network, you will likely see WEP devices. So identifying what the SSIDs are specific to the hospital and which ones you can go after. They might sometimes tell you, do not go after this specific device because it's sensitive or something like that. Also, understanding their domains, and this is based on experience. We were doing a pen test back in, I think, 2016. This organization had an AD domain, an Active Directory domain that we got into with 3-character passwords, 3-character usernames. It was Windows Server 2003 domain controller, and every other server was around that timeline too. Turns out, because once we got domain admin pretty quickly, couldn't believe it because the organization looked pretty good otherwise. We went and talked to the CISO who hired us, and they said, well, I have no idea who this is. That's very scary at that point. We have a domain in your network range, an Active Directory domain with servers and users that you don't know who that is. Talk to the IT manager, had no idea. Talk to compliance, they had no idea. Biomed, which is a department that manages biomedical devices in the environment, they had no idea. Well, that's pretty scary. So let's bring everybody together and see what's going on. We did some research on our own. The client also talked to their contracts department, and it turns out this was an EMR vendor about 5-6 years ago, came in, set up an Active Directory domain for their devices. And it was communicated, but the person who was communicated to no longer was there. It was in the contract, so everybody just thought, it's in there, they'll know, but of course the client didn't know. So inventorying while you are doing the pen testing might actually be helpful for your client. All right. So that is it. That's not all I want to talk about with healthcare, but this is all that's important and I want to talk about in this time slot. That's my Twitter handle right there. This right here is my LinkedIn page. If anybody wants to go and connect, I'm happy to talk about anything. I'll also be at Discord to answer any questions you all may have.
I think I can come up with at least one that I'm interested in and one that everybody might be interested in.
Yeah.
We were discussing open source computerized patient records and clinic software earlier, and we speculated that there's probably some legislative block to that the big companies managed to get past. Are you aware of anything like that?
Not specifically, but I can tell you those big companies do have a lot of lobbying money. Healthcare is very lucrative business. For example, if you look at the cost of moving from Cerner to Epic or Epic to Cerner, it's in millions. So I would not be surprised if they're lobbying against open source EMRs and things, or open source recognition, things like that. There are open source EMRs that I'm not seeing used a lot either. A lot of it has to be with support, right? Because the healthcare organization needs support for whatever tool they're implementing. And they want to make sure that they just don't feel comfortable with open source because of that. Right?
Okay, and then you said don't do webcam captures unless you want to see something nasty. Can you give a high-level overview for everybody about what you might want to avoid?
What do I want to talk about, though? That's the thing in there. So organization wanted webcam shots because the person who hired us, the security organization, was just really being pushed against the corner on the budgeting. The CFO, and I'm kind of paraphrasing in here, but CFO said, I have enough money to pay HIPAA breach fine. I don't need to worry about security. That was the business decision that the CFO had made. And the security team that hired us wanted us to prove that wrong. They wanted us to specifically get desktop screenshots and get webcam screenshots of executive leadership and board of directors. And that once we took some webcam shots, we saw things that would look really good on a tabloid, would not really look good in a Pentest report. Another instance, similar issue, we were asked to do webcam screenshots, and one computer that we did not think, because they had some pretty good naming scheme about which computer is where, and we were avoiding any computers in patient rooms. But we ended up taking a screenshot from a computer in a patient room that was not good to look at.
Okay.
Reported that right away. It went through quite a bit of investigation by compliance and whatnot. But both of those organizations, they of course gave more money to security and whatnot, but they also weirdly reissued everybody a laptop without a webcam.
Which also seems kind of expensive, but a
Priorities.
good idea. And epoxy would achieve the same thing, but might make the laptop hard to close. All right, thanks a lot, Q. We really appreciate you presenting today. It's a fascinating topic, and I'm sure there'll be some questions in Discord if you want to. And then if you get a chance, and you're willing to, or share your slides, if you get them back to the CFP, get them in the Discord if you want, and then maybe back to the CFP so we can get them into the YouTube when we share there.
I'll do both. I'll drop the slides in there shortly in Discord, and I'll email you guys with the slides too. Thank you for the opportunity. Thanks, everybody.
Thank you, sir.
Thanks.
Thank you.